Hi, everyone. Thanks for joining us today. It's a pleasure to be here, and I'm excited to talk to you a little bit about concussions and the new age of concussion assessment and treatment. Just real quick, no disclosures or any conflicts of interest to report pertaining to this talk. And I do want to show you this slide. This is probably my favorite slide when I talk about concussions. The way we think about concussions now is we treat it as a multi-system injury, meaning that can affect a lot of different parts. Clearly, it affects the brain, but it can be autonomic, it can be ocular, it can be vestibular, it can be mood, headache, a whole bunch of different things. And that's exactly what we need to be looking at, is we need to have a multi-system approach to looking at the concussions. And when we conceptualize an assessment, I kind of drew it out here a little bit to show you what we're trying to focus a little bit here on. What we're trying to do is we look at some risk factors at first that we might be able to see on an individual. And what you can see here is we have previous concussions. Migraines can be a factor. If there is a history of migraine impairment, then they may be more prone to headaches. Things like learning disabilities, ADHD can be factors as well. If there's pre-existing depression or anxiety, that can lead to longer recovery or greater symptoms following concussions. Even simple things as a history of motion sensitivity. Kids who get car sick are prone to having vestibular disorders after concussions, and things like a lazy eye can all be factors. When there's a concussion, and they're going to come in for clinical assessment, what you'll see is that we have 7 areas or systems that we're paying attention to in our assessments. We have vestibular, we have ocular, we have cognitive fatigue type of thing, headaches, autonomic, cervical as well. So there's a lot of different areas that we need to pay attention to in our clinical assessment. When we find these deficits, these create clinical trajectories, areas that we need to focus on and areas we need to start working on in treatment. And then, one of my points that I keep hammering over and over is concussions are treatable. This is absolutely an injury that we can help patients get better quicker. Okay? I'm going to go through the trajectories a little bit quickly, but I do want to try to hit on a couple of points for all of them. So the first one for the cervical trajectory. Whiplash, cervical strain, very, very, very common in concussions. Areas to pay attention to are occipital and trigeminal type of headaches and pain. Remember that in a concussion, there is a lot of movement of the head, particularly if it's a weaker neck, such as in female athletes. C1, C2, and C2, C3 are the most common areas that are stressed or strained, and you can irritate the occipital and the trigeminal complex to cause the headaches. Headaches in the back of the neck are obviously occipital, but even headaches at the vertex or even periorbital around the eye, lower forehead around the eyebrow, kind of indicate that it's coming off of the trigeminal, the first branch of the trigeminal, and that's something that we do try to pay attention to treat appropriately. When you do your exam, you got to have range of motion with resistance. You got to look for that tenderness, trigger points. And if you do feel that there is a significant cervical component, think about having them do massage, heat, ice, and maybe even physical therapy early on to help treat that cervical strain quickly. In terms of medication management for the pain for the headaches, my approach tends to be a little bit more conservative. Initially, for the first week or two, try to stay away from any of the heavy hitter medications, and we try to stay with some of the over-the-counter stuff and maybe some anti-inflammatory to help with inflammation in that area. Next area to pay attention to is vestibular and ocular motor trajectories. Vestibular, ocular, and the ocular motor deficits are common acutely in concussions. Upwards of 80%, 70 to 80% can have these types of deficits immediately after a concussion. Now, the vestibular part, it's not true vertigo often. Sometimes it is, but a lot of times it's more of the phrase I like to use is rocky boat, or feeling off balance, or the ground underneath them is not stable. That type of dizziness is much more common in individuals following concussions. The other thing I like to pay attention to is the difference between dizziness and lightheadedness. A lot of times patients will say they're dizzy when they actually mean lightheaded, such as orthostasis. So try to make that distinction quickly. Ocular motor, you always have to pay attention to 3 areas: saccades, vergence, and pursuits. And when you do your examinations with your patients, these types of deficits, the vestibular and ocular motor, are major sources for fatigue, headache, and cognitive problems. They will impact their mood, their energy levels, their ability to go to work, to go to school, exercise, and driving as well. When we look at some of the balance, to assess balance, there's 2 types of ways of doing it. One of the ways of doing it is right here, as you can see, is what we call static balance, and that's the balance error scoring system, which has been around for a good 15 years or so. But what we're starting to find out is more, when we're looking at here, is more dynamic balance. That tends to be a little bit more sensitive to concussions, particularly in our athletes. There are different apps that can be used to measure balance using the gyroscopes in your phone. That's very, very accurate and helpful. We can also assess gait disorders following concussions using various apps. So we do recommend that you kind of consider adding balance assessment to if you're going to look at your concussions. And a very nice screen, the vestibular ocular motor screen, was developed in 2014 by Mucha out of the University of Pittsburgh. It's a very nice, quick assessment. Once you're proficient in it, it could take you about 3 minutes to kind of go through it, and it will measure aspects of vestibular, ocular, and ocular motor functions that will be sensitive to concussions. Typically, 70% of individuals acutely after a concussion will have a deficit on the test here. In terms of if you do find the deficits, I am a proponent of looking at treatment earlier on in the course. Not uncommon for me to send them home with home exercises, even the Epley or Brandt-Darhoff exercises. I will train them very meticulously and very carefully and make sure they know how to do those types of exercises. We look at gaze stabilizations, a whole bunch of different home exercises that we can send with the patients. I prefer starting earlier, 5, 6, 7 days after concussion, rather than waiting too long. We can always consider more formal vestibular therapies if they're not responding well, if they have lingering deficits, but at least starting them with some home exercises gives them a chance of getting better a little bit faster. In clinic, we do use some sophisticated eye tracking techniques to help us a little bit better narrow down some of the deficits and treatments. There are various technologies out there that to use. The one that I like to use the most is iSync. And when we do that, I want to give you a quick example. This was a 17-year-old female basketball player that was knocked down, hit her head on the court. And she had very, very significant ocular motor deficits. And you can see about 2 days after the concussions, when I saw her, as the first panel on the left, you can see her saccades, her pursuits of just following a red dot in a clockwise fashion. You can see how abnormal her tracking was in both eyes. And then about 3 days after the concussion, 4 days after the concussions, we started her some exercise, comes back about a week after the concussions. And what you can see is a significant improvement in her eye tracking abilities that continued out through about 5 weeks after the concussion. And again, for just saccadic movements in vertical and horizontal, you can see the exact same pattern of significant impairment on the far left when we first saw her. And if you work over to your right, you can see significant improvements in that scanning and vertical and horizontal tracking. Ocular motor exercises will also send home with the patients to start early on. A lot of it depends on the age and what kind of tasks we're going to do with them. We can work on issues of vergence, tracking saccadic movements, pursuits. There's a whole bunch of range of exercises that we can send home with them. Same kind of thing. We start off light. If they help them out, then we're good. If they're not really helping and we still need some treatment, we can try some formal vestibular therapy. Next one is cognitive. Attention, reaction time, memory are very, very common to have in the first 48, 72 hours. Usually after that, we start to see an improvement in these areas. Computerized testing for cognitive deficits and concussions are very, very common. Newer some use laptop computers. Others are now going off of the cell phone and using tasks off of that. A lot of them are very well and very useful. What I find useful in terms of the cognitive assessment is using them for clearance. I don't necessarily use it to diagnose a concussion. You're going to see those deficits early, and so you usually don't need to just do any assessment to diagnose, but I tend to use it for clearance. Once I'm ready to get them back to their sport, to school, to work, I'll do some cognitive assessment to make sure that everything is intact. Symptom reporting is probably going to be the one you use the most. This is the post-concussion symptom scale. You should be able to, if you did Google Images, you should be able to find this one very, very easily. It's a questionnaire we developed back in 2006. We look at 22 symptoms. Each symptom is rated from 0 to 6, 0 being nothing, 6 being severe. And it's something that we obviously track with. And my recommendation is you send them home with the sheet and give them specific dates to fill this out. And this way you can track them over time in between clinic visits. And it's a very nice, helpful way of looking at it. And it also allows you to look at the constellation of symptoms. What we see after a concussion is there's kind of 4 different areas that we see symptoms cluster. There's this cognitive fatigue headache pattern, affective, so mood, depression, anxiety, irritability. Somatic would be like a little bit of the headache, dizziness, light sensitivity, sound sensitivity, and then obviously there's the sleep component. Please remember, females tend to have greater symptom reporting even at baseline, so you can't compare males and females. Age is a factor, does affect their symptom reporting. And other things is you do have to remember that the symptom reporting is subjective. So it can be skewed by individuals that sometimes over-report or sometimes under-report their symptoms. So we do allow for that a little bit. And like I said, it's a great way of tracking their symptoms over time by letting them take it home. There are some apps that allow you to do it through an app, and that way you can look it up through the web-based service to track their symptoms. Brings us to psychological and emotional factors. Often play a very strong role in concussions. One of the things that you have to be careful about is expectation is etiology. Dr. Google can give patients a lot of bad information, and patients start worrying about CTE after having a simple concussion and kind of get a little distorted in their thinking. So psychoeducation, educating the patient very early on in your first visit about what a concussion is, what to expect, recovery patterns, how they can help themselves, go a long way in helping a patient recover. Anxiety and depression do increase after a concussion, and even without a history of depression or anxiety, you can have some depression and anxiety kick in. A lot of times initially it's irritability. You'll see that a lot in our high school kids, but a pre-existing history of anxiety, depression, bipolar disease, for example, can cause a protracted recovery in much harder patients. And these are patients I pay a lot more attention to in the recovery process. Exercise withdrawal, if you work with athletes, these are individuals used to exercising a couple of hours every day. If you cut them off real short and real quick, what you'll see is they can have a little bit more increased irritability and sadness going on. Poor sleep will increase some of the depression and anxiety and have an interchange there and can affect recovery. And the other thing you have to pay attention to is stress and anxiety in high achievers, people with low self-esteem, people under a lot of stress. If they're very stressed about returning to work or missing school, that anxiety can exacerbate symptoms. Please remember, anxiety increases cortisol. Cortisol heightens our sensory awareness. So if you already have headache, if you already have sensitivity to light and sound, the increased anxiety will heighten those. I kind of use like the volume control gets turned up. So it's very important to try to manage that anxiety. Another area, autonomic dysfunction, tends to fly under the radar. A lot of gets missed a lot of times, and it's something that I do think we need to pay a lot more attention to. Autonomic dysfunction in a concussion is due to the rotation or the torquing of the brain. So when there's a lot of side movement going on, we can see that it causes a strain on the brainstem. It affects the medulla, and that affects its ability to control the arterial baroreceptors and heart rate. Most common thing we pay attention to is heart rate variability. And that can affect our breathing, and that can affect oxygen, carbon dioxide ratios. So it can really affect how the brain is functioning. If heart rate variability is out of whack, is out of control, that does affect cognition. So we really try to pay attention to that heart rate variability. And there's a lot of nice wearable devices that do a very nice job of measuring heart rate variability. It's very common to see autonomic dysfunction within the first 72 hours. When you're evaluating your patients, please ask about these: lightheadedness, feeling hot, feeling cold, night sweats, constipation. If they talk about flutters, things like that, pay attention to a lot of those autonomic features. Often it does recover in the first several days. Sometimes we do have cases where it's much more prolonged, weeks, months, and sometimes even longer. Just a little bit in the background, we do see it in about a third of our teenagers acutely with the autonomic dysfunction, so we do try to have a lot of precautions for them. There is a higher rate of this autonomic dysfunction in teenagers with prolonged concussion symptoms. So sometimes it is a contributing factor to persistent symptoms in individuals. There is always formal assessment techniques, but we don't necessarily recommend those. But things that you can do in your office would be something like orthostatic blood pressure assessments. It takes a little bit of time, but it can give you a lot of information about how to look for autonomic dysfunction in patients acutely. There are techniques for formally assessing and treating autonomic dysfunction. Dr. Letty here developed the Buffalo Concussion Treadmill Test. And while they're doing physical activity, we do measure heart rate and blood pressure. And it's a graduated, very systematic method of increasing cardiac resistance and output. And what we're doing is we're looking at sudden jumps in blood pressure or heart rate and perceived exertion. And that kind of shows us where the autonomic dysfunction is, kind of serves as a baseline, and we can rehab them at that level. Works very, very well. It can be used diagnostically to look for that autonomic dysfunction in concussions. Important area: headache and sleep. Very, very common. Headache is the most common symptom after a concussion. Upwards of 80-90% of individuals will have a headache. We always, like I mentioned earlier, very, very important to determine the source of the headache. I'm very much for curing and treating the headache and not just medicating the headache pain. So I'm very, very careful about the questions I ask them about location of the headache. When do you feel it? Waking up, not waking up. So individuals that wake up with a headache that get better in the day after a concussion, that's clearly a cervical related problem. So we know how to treat that. When I start with the treatment, I'm much more conservative. No NSAIDs in the first 48 hours of concussions because of their blood thinning properties. But I do tend to stay with over-the-counters for the first couple of days. Do have to be careful about rebound effects, so you don't want to keep them on the over-the-counter stuff for too long. And always consider some of those home treatments of ice, heat, massage, and stretching. And then if that's still not improving, then we can always do formal physical therapy. If they do linger with their symptoms, then obviously some structural imaging, MRI, to look at the alignment and the ligaments and discs can always be helpful. Sleep can also be altered, either too much or too little sleep. A lot of times can be tied into headache, exercise withdrawal. We do emphasize the sleep hygiene without excessive napping later in the day in particular. And if you always think about trying some melatonin, we usually recommend 5 to 8 milligrams to start with in terms of the treatment. Just a little bit about recovery. One of the general things, and kind of highlights the talk, is coming out of the dark. No longer do we recommend that patients stay isolated without any sensory stimulation. In the past, keeping their kids in a dark room was very, very popular. That we find is actually detrimental in the long term. After about 48, maybe 72 hours of rest, a little bit more sleep, then we do start to do what we call symptom-limited recovery or activity. And what we want to do is to get them moving physically, cognitively, even if it's only for a couple of minutes, even if they go for a 3, 4, 5-minute walk, or they spend a couple of minutes on the computer reading, listening to music, watching TV. We need to start getting them moving. It's a little bit of a what we refer to as a Goldilocks approach of not too little and not too much. And once we get in that range where they can start doing some activities without a significant increase in symptoms, we slowly, gradually increase that over time. And that's how we kind of get them back to their normal level of activity. Those individuals that rest too much and decrease stimulation do take longer to recover from concussions. And just real quick, we talked about the recovery first 2-3 days. We're going to really rest them a lot. After day 3, we start some of that light activity. And as I mentioned to you early, I think it's very, very important to educate your patient on what they experience, what the problem is, how you're going to help them get better, and what the expectation is for recovery, okay? We do reduce electronics initially. We absolutely limit driving if they're concussed, no alcohol, and we do consider formal treatment 7-14 days into the time course. There's a couple little hacks you can always do to the computer to reduce that brightness and get rid of some of that blue light for the individuals, which we do find helpful as well. So just to summarize, as I mentioned, concussions are a multi-system injury that requires a comprehensive evaluation. We have these 7 areas of cervical, vestibular, ocular, motor, headache, autonomic, cognitive fatigue, and the balance problems that we do see. So those clinical profiles will determine the clinical trajectories and the treatment and the direction that we're going to go. The concussions are treatable, and we can help them get better faster if we know what to treat. So with that, we will consider the treatment options a little bit sooner. Remember those home exercises versus formal therapies. Don't be afraid to start the home exercises, but you have to make sure you educate your patient on making sure they know how to do those exercises correctly, and make sure that they can have some feedback and some handouts to go along with that. So with that, I will end. Thank you very much for your time, and have a good day.